Good evening, sir.
Good evening, Balram sir. How are you, sir?
Everything is fine. आप कैसे हैं?
एकदम अच्छा है, अच्छा
Good
है.
evening.
Good evening, Sarita ma'am. How are you, ma'am?
We're live.
Yeah.
Good. I'm good. I'm good. Thank you. And
Virendra ji.
welcome.
Good evening, sir. Good evening, ma'am.
Yeah. I'm ready, ma'am. Anytime.
Thank you. Thank
Yeah.
you. Pramila, please start.
So shall we start, ma'am?
Yes, please.
Okay. So good evening, everyone. We welcome you to another webinar on thyroid clinics, which we do every Wednesday as a part of the educational initiative by Indian Thyroid Society. So at the outset, I welcome our president, Dr. Sarita Bajaj ma'am, and our patrons, Dr. K.M. Prasanna Kumar sir and Dr. R.V. Jayakumar sir. And today we have another interesting session lined up. Before that, just two things, that we have a journal, which is Thyroid Research and Practice. I request all of you to please send articles for the journal, because we need more articles for our journal, because we are trying to make our journal indexed for Scopus and later on, obviously, for PubMed. So please try to send as many articles as you have on thyroid to our journal so that we can get some more articles for our journal. So I welcome today's chairperson, Dr. Balram Sharma. He is professor and consultant endocrinologist from SMS Medical College, Jaipur. And he has various achievements to his credits, including an outstanding faculty award by SMS Medical College, Jaipur, and A.B. Gandhi Award for Excellence in Endocrinology. And he has around 31 publications in indexed journals. So he will be taking us through the session, first session, that is, there are 2 journal articles to be discussed, and he'll introduce the moderator as well. And then we have an interesting quiz coming up by Dr. Saptarshi after the 2 journal club articles. And then we will be going ahead with the next, the third agenda for our session today, which the chairperson will be telling us about. So I welcome Dr. Balram Sharma and request him to take us through the sessions now.
Good evening, Dr. Pramila. Thank you, Sarita ma'am, for giving me this opportunity and inviting me to this interesting program. And I was also part of audience among the last few programs. And I came to know that how interesting and how scientifically enriching this program were. And every program is actually creating more awareness, more interest in the field of endocrinology, and most of the endocrinologists now are waiting for the Wednesday, that when the Wednesday will be there and we will be learning few more lessons and from the different topics. So in continuation to the previous series of this whole program, today again we have the interesting journal club session now. Then Dr. Saptarshi, as usual, is again clinically very active, scientifically very active. He will be discussing about an interesting quiz, and the winners of quiz will be also awarded. And finally, we will have the monologue program. But to moderate the session, me and Dr. P.K. Jabbar is there. Dr. Jabbar needs no introduction in this country. Everybody is aware about Dr. Jabbar's name and his credentials. And but just for this ceremonial openings, I would like to introduce him. He is a professor and head of Department of Endocrinology and director and CEO of Indian Institute of Diabetes at Trivandrum. He was organizer of ESICON 2017. Everybody is aware and remembering the memories of that fantastic program. He was also organizing secretary of RSSDI. He is a regular medical council inspector and postgraduate examiner, including DM courses. So over to you, Dr. Jabbar, for the proceeding of the today's program, as we have 2 young budding endocrinologists, senior resident from KEM Mumbai, Dr. Aditya and Dr. Anima will be presenting 2 interesting journal articles, and they will also be interesting as well, eye-opener for all of us. Over to you, Dr. Jabbar. Thank you.
Good evening, everyone. Regards from Trivandrum, Kerala, God's own country. And respected chair, senior person, Sarita ma'am, Dr. Balramji, Dr. Prabila, and my colleagues, ladies and gentlemen. I'm extremely happy to sit in the post of moderator for this session for today's ITS program. And we have two programs today. Both the papers are presenting from my own institute. I'm a KEM student. Okay, I finished my DM in 1997. So I'm very proud to say that my colleagues are presenting papers today from reputed journals. First session will be discussed by Dr. Aditya, and he will be presenting a beautiful case of journal of prevalence and significance of non-uniform thyroid radioisotope uptake in patients with Graves' disease. I don't want to discuss much, and I want to sign off for the time being. We'll listen to Dr. Aditya and we'll have a discussion also. Over to Aditya for proceedings and presentation. Thank you very much.
Good evening, everyone. Am I audible?
Yes, you are. Go ahead.
And are my slides visible?
Yes, Babu, it's visible, very clear.
Good evening. I'm Dr. Aditya from KM Endocrinology Department, and today I'll be presenting this journal club on the topic prevalence and significance of non-uniform thyroid radioisotope uptake in patients with Graves' disease. This article was published in Clinical Endocrinology in February this year, and it was done by UK group from 3 institutes by Abdalji sir et al. Introduction to the topic. As we know, incidence of Graves' disease is 20 to 30 per 1 lakh individuals per year in iodine-replete countries. And the risk of Graves' disease, as calculated in various studies during lifetime, is 3% for females and 0.5% for males. And the peak incidence being between 30 to 60 years. Diagnosis of Graves' disease is done by raised TSH receptor antibody levels or a uniform uptake on radio-labeled isotope scanning, either with iodine or a technetium-99 scan. Previously done studies have mentioned the prevalence of non-uniform uptake in Graves' disease anywhere ranging from 0.3 to 56%. Hence, the objective of this study was to evaluate the prevalence and the clinical significance of non-uniform uptake in patients with Graves' disease. This was a prospective study which was conducted from July 2005 till March 2018 over a period of 13 years, wherein consecutive patients who were referred to an outpatient clinic were included in the study with biochemically proven first episode of hypothyroidism, which was diagnosed as Graves' disease, and a total of 276 patients were included. Graves' disease diagnosis was confirmed by endocrinologists, and this was based on 2 strict criteria with a raised pre-thyroid hormone levels with a suppressed TSH and a raised TSH receptor antibody level or a uniform radioisotope uptake scan, both of which were done before starting the patient on antithyroidal drugs. So the patient needed to have raised pre-thyroid hormone levels with a suppressed TSH and a raised TSH receptor antibody or a uniform uptake on radioisotope scan. Drugs which were used for Graves' disease treatment majority were treated with carbimazole, around 95%, and very few patients were treated with PTO as per the patient's wish or those who are planning pregnancy. And they were treated with antithyroidal drugs until the TSH receptor antibody levels were near to normal with some degree of flexibility. And titration of the antithyroidal drugs or the need of using block replacement regimen was left to the clinician and as per the patient preference. Even after the study was, the inclusion time was till 2018, these patients were monitored for risk of relapse after antithyroidal drug cessation, which was monitored in June 2021. Exclusion criteria for this patient, basically 31 patients were excluded because of absence of radioiodine uptake scan. Either the patient refused or the patients were pregnant or breastfeeding. Of the total patients, 7 patients were not included in follow-up analysis as they were lost to follow-up, or they were treated with definitive therapy with surgery or radioiodine, or were not treated due to subclinical hypothyroidism. Biochemical evaluation of these patients was done with the TSH, FT4 and FT3 level. The reference ranges is as given below. and a third generation TSH receptor antibody, normal level of which was less than 1.18 units per liter. They were analyzed by Roche CLIA method on COBA's analytical platform. After doing the biochemical evaluation, the patient was subjected to radiological evaluation with a technetium-99 uptake scan, wherein the patient was in supine position, IV 80 megabecquerel of 99 technetium was given, following which 20 minutes later, anterior views of the thyroid were obtained with gamma camera, and these scans were then graded by 2 nuclear medicine specialists, both of which were blinded for TSH receptor antibody status, and based on which the uptake was described as either uniform or non-uniform. And any ambiguity was resolved by mutual discussion. Statistical analysis was done with the SPSS software 27, and a p-value of less than 0.05 was deemed statistically significant. Coming to this baseline characteristics, of the 276 patients, 25 patients, that is around 9%, had non-uniform uptake, whereas 91% had uniform uptake on technetium-99 scan. Both of which were described in terms of age, sex, ethnicity, smoking, whether they had Graves' orbitopathy, biochemical evaluation, and an average daily dose of antithyroidal drugs with duration of treatment with 80 days. So what we found in the study was that those patients who had non-uniform uptake were elder as compared to uniform uptake group. They had lower elevation of the free thyroid hormone levels of FT3 and FT4 levels as compared to the uniform group. And they had a lower baseline TSH receptor antibody levels as compared to the uniform group. All this was statistically significant. So what they found was 95% were treated with carbimazole and rest with propylthiouracil. With regards to the median trial, at the time of stopping the therapy, it was statistically non-significant in both the groups, as was the risk of relapse in both the groups. The hazard plot was done for the risk of relapse in non-uniform group and uniform group. As we can see, the hazard ratio for non-uniform group is 1.74 as compared to uniform group, but this was statistically not significant with p-value being 0.07. They also compared groups as per TSH receptor antibody negative and positive status of all 16 patients, that is 5.8% were TSH receptor antibody negative, and those who are negative were elder. They also had lesser elevation in free thyroid hormone levels as compared to TSH receptor antibody positive group. All were statistically significant. These were 24 pictures of the non-uniform uptake scan, which finally were diagnosed as Graves' disease. As we can see, multiple scans, unilateral non-uniform uptake. One patient's scans were no longer available with them. Coming to discussion, so as we saw, almost 1 in 11 patients with Graves' disease had non-uniform uptake on technetium-99 scan. Those patients who had non-uniform uptake were older and had lower elevation in thyroid hormone levels. Hence, it is recommended that TSH receptor antibody level assessment be done at baseline for diagnosing Graves' disease, and radio-labeled scan or an ultrasound scan may be reserved for TSH receptor antibody negative hyperthyroid patient for the diagnosis of Graves' disease. We'll just go through a few guidelines. These are nice guidelines published in 2019, which mention TSH receptor antibody levels to be measured for etiology of all hyperthyroidism patient, and technetium scanning to be considered only if TSH receptor antibody is negative. This is in contrast to 2016 American Thyroid Association guideline, which mention TSH receptor antibody or uptake scan should be done only when the etiology of hyperthyroidism is unclear from the presentation in biochemistry. Even European Thyroid Association mentioned in 2018 in their guidelines that TSH receptor antibody to be recommended for all hyperthyroid patients, and the uptake scan to be reserved only if there is coexisting thyroid nodularity. There were surveys which were done in Europe and US. So this survey, which was done in 2013 in Europe, which was published in Clinical Endocrinology in 2015, wherein they gave a questionnaire to all the endocrinologists from Europe to know which line of investigation is being done for the diagnosis of hyperthyroidism patient. And it was seen that 85.6% of endocrinologists asked for a TSH receptor antibody levels, whereas only 37% of patients asked for an isotope uptake scan at the time for diagnosis of hyperthyroidism patient. This is in contrast to US group. They published a study in JCM in 2011. Again, a survey was done, and they mentioned that only 54% of the endocrinologists asked for a TSH receptor antibody level for the diagnosis of Graves' disease, and 45% of patients, which is equal to the 54%, asked for an isotope uptake scan for the diagnosis of Graves' disease. So coming to implications of the study. So this study gives us idea that if radio-labeled isotope scans are used alone, Graves' disease may be missed or misdiagnosed as toxic MNG. This may lead to clinician opting for a radioiodine or a surgery for the first line of treatment rather than giving antithyroidal drugs. Among the non-uniform uptake group, aging is a significant predictor of non-uniform uptake. The explanation being nodular thyroids are more commonly observed in older people. When comparing the non-uniform group with the uniform uptake group, the treatment with antithyroidal drugs has got similar consequences, with there being no significant difference in the risk of relapse in both the groups. Hence, the uptake on technetium-99 scan should not determine treatment options. Again, this reinforces the existing guidelines mentioning TSH receptor antibody to be done initially and technetium-99 scan to be reserved for those who have borderline or low TSH receptor antibody levels. Strengths of this study were that it was a prospective study with large number of Graves' disease being confirmed by the third generation TSH receptor antibody levels, and a long period of follow-up was also done to detect relapse. However, there were a few limitations of the study. There were no ultrasound data to confirm indeed the non-uniform uptake correlates with the nodular thyroid gland. Also, there were lack of standard guidelines while doing the uptake grouping into uniform and non-uniform. Reporting may have been subjective. All hyperthyroidism patients at the time of entry into the study did not have both TSH receptor antibody and isotope scanning. All the patients in the study had both the investigation being done. Hence, this may have led to a selection bias because the patients who had borderline TSH receptor antibody levels were more likely to be included, and those who declined radioisotope scanning being excluded from the study. So coming to summary of this study, as I mentioned, 1 in 11 patients with Graves' disease are likely to have non-uniform uptake. Hence, a TSH receptor antibody level should be taken as a first line for diagnosis of all hyperthyroidism patients, and isotope scanning to be reserved for those who are TSH receptor antibody negative. And treatment of both non-uniform and uniform group appears to be equally effective with antithyroidal drugs. However, further studies with a larger number of patients are required. I will just come to one case capsule of a patient which we saw recently in our department. He was a 24-year-old male presented with 1.5 months of neck swelling. On examination, he was toxic with tachycardia, had a grade 2 goiter, left nodule palpable. His thyroid function test showed raised T3, T4, and a suppressed TSH. Hence, was advised to do a technetium-99 scan, which showed a non-uniform uptake. Our TSH receptor antibody levels were asked for, which were positive. However, when we did in view of the cold area in the left lobe, we asked for an ultrasound, which showed a thyroid nodule, and an FNDC from this left nodule showed Bethesda category 6. Hence, he is planned for surgery for in the future. I'll just like to mention about one meta-analysis which was done in 2015 regarding thyroid carcinoma and Graves' disease. Those Graves' disease patients who had thyroid nodules, the risk of carcinoma was 23%, and those who did not have nodules were 5%, with most commonly papillary thyroid carcinoma being 88%. I just highlighted this case to mention that there is risk of malignancy in Graves' disease as well. Hence, we should do a careful screening, investigation, and manage the patients well. Thank you.
Dr. Aditya, it was a very nice and lucid presentation. Messages are very clear. I think the topic is very interesting topic, I would say. And the carry-on messages are very, very good. Okay, so it's probably today also we had a same type of problem. Okay, nodularity in thyrotoxicosis. Bit confusing. The conventional teaching is if the patient has got a nodularity, always we should be very, very careful. And I don't want to look into the carry-on message and final outcome for the study. Dr. Arun was asking, first question is really invalid because he was mentioning without listening to the last slide. Okay, second question is a very valid one. Did you go through needle cytology or the study, okay, for patient with cold nodule? There are cold areas also, right? Is there any mention about those things?
No, sir. Regarding in this study, there was no ultrasound and there is no fine needle aspiration cytology which was done for the cold nodules in those 25 patients.
I think that is one of the important points. If the patient has got a nodularity, in the summary also you have mentioned that there are nodules and nodularity. Of course, you should look into, say, religiously you should look into the evidence of malignancy, right? That is one point. Okay, Sarida ma'am, what about your comments and suggestions for this paper? Sarida ma'am. Sarida ma'am.
I'm here.
Yeah,
I'm very much.
please. Yeah, madam,
Just
your
unmute
comments.
myself. Yes, I think this is a very nice presentation. Yeah. We have people here from at least 4 institutes. If I include Pramila, of course, though she's part of the organizing committee. We have Dr. Balram from Jaipur and Dr. Jabbar is with us, Dr. Patil, of course, and his team from KEM and Pramila from MS Ramaiya. So all of you must have your policies. I mean, departmental policy as to how you approach. So I just want to know how does it differ, or in all cases you are doing thyroid receptor antibodies if you're suspecting Graves, both. How are you deciding in which patient you are doing both and which patient practically in your setups?
Start from my data from Quantum Medical College, Kerala. See, we are all doing both these two investigations, but we have a small issue of thyroid receptor trap antibody assay problem, right? Suppose if the patient has got a negative trap and say MNG like picture in technician scan. So where we stand, we do not know. Okay. So the reliability of trap or thyroid receptor antibodies is a small issue in our Kerala, especially certain part of Kerala, but still we are doing it. Okay. Both investigation.
You're doing
both. We can, Balramji, what are your comments, Balramji?
Dr. Balram.
So the similar is the situation here because many times because I am working in a government hospital, so sometimes the cost is one limitation because initially that was not available to our laboratory, but now that is available to us as well. So initially we were selecting few patients, means where we have the confusion in the diagnosis or we have some issues in the confirmation of the Graves' disease diagnosis, then we used to get it done. Sometime in the thyroid orbitopathy patients also, when they were euthyroid and we were getting these done, that was the specific indication that we used to do the trap. But now in most of the cases we are doing, because now this is available at our institute also, and that is now free of cost available. Means every investigation is free of cost now in our hospital. So we are getting the trap as well.
Both. Your answer is both. You are doing both.
Yeah. I think I will get the opinion of Dr. Pramila, Bangalore data.
Yeah, we are not doing trap for everybody because it's a costly. The reason for not doing it at the beginning is a cost, because ours is a corporate hospital and a medical college both, but all our patients cannot afford trap. Yeah, so we are doing it where we have a diagnostic dilemma there, or on follow-up when we are deciding to stop the medication. At that point of time, we definitely do it because that gives us an idea about the relapse, and also that's the point of time where we exactly use it. In pregnant patients, obviously we use it, and obviously where we have a diagnostic dilemma, like cases where we don't know whether it is a toxic versus a Graves, there we definitely do it. Orbitopathy cases, as Dr. Balram said, where they are euthyroid, we definitely do it. So those are the definitive indications. The others, like, it's arbitrary. If it's an affordable patient, we may do. If it's not, we may not do it at the diagnosis if we don't have much of diagnostic dilemma.
Given the choice, you do both.
Yeah,
I would not
Given
do
the
both
choice.
for all patients. I would do only for the patients where I have a diagnostic dilemma, because scans are easily available. If definitely there's a diagnostic dilemma, I will do. Yes, definitely. But when I'm stopping treatment or trying to stop after 2 years or something, I would definitely do it. That is where I'm doing it definitely.
I think
Saptarshi is sitting in the top. Okay, we will listen to Dr. Saptarshi.
I think I agree with Dr. Pramila, because we are working in corporate
Selective.
hospitals and patients have to pay for their investigation. So we need to justify why we are ordering it. So most of the cases where I think it's all valid that in pregnancy is one situation where it has an important role, and during discontinuing therapy, if we are planning to discontinue therapy, some cases of grave subthermopathy, and so I agree with Dr. Pramila.
Can we move on now, please?
Pregnancy and
I
orbitopathy.
think
These are the two
Virendra
situations where we need to do it.
Yes.
So
this
same
paper
is
is
the
from,
situation, I think, at every institute.
yeah.
I
I
think we
think, sir,
should
we'll
move on
listen to
now, please.
Virendra also, sir.
Yeah.
Madam, Virendra, one sentence from
Yes, sir.
Virendra. What is
Yes,
the
sir.
protocol at KM?
Yeah, at KM hospitals, we are not doing trab levels in house, and the technetium scan is easily available in the KM hospital as well as the next institute, like radiation medicine center, which is next to our hospital. So we generally go for the technetium scan only in those patients with asymmetric uptake, to differentiate between whether it is MNG or whether it is Graves. We do trab levels in some cases, and rest of the cases, like ma'am has said, in pregnancy or in the euthyroid orbitopathy, we get trab levels.
Thank you. Can we
That's
move
right.
on, please?
Yeah. I think, shall we move to the second paper,
Yes,
ma'am?
please. Yes,
Yeah.
please.
Please. Anima?
Good
The
evening.
second paper is also from KM Hospital. Dr. Anima will be presenting the paper, and she is presenting the normative data, something like that. Okay. Over to Dr. Anima. Please share the slides also.
Yes. Just a second, sir. It's allowing me to share my presentation.
Yeah, relax. Take your time. No issue.
Aram se.
Yeah, it's no hurry. It's okay. Just click on your share and then go to the slide. Open the PowerPoint on your screen first. Then go to
Did you open it?
share and then share.
Chalo, Aditya is there. Good.
Yeah.
You need to have opened the presentation before on your desktop.
I think 2 are on, so you have to switch off one. If otherwise it'll echo. The voice will echo.
Is Aditya with you?
She's come to Aditya's screen, I
Yeah,
think.
she has, right.
Yeah. Yeah, we can
It's
see.
great.
Yes, yeah.
Am I-
Yeah. Just
my
make it full
screen
screen.
visible
Yes,
now,
go
ma'am?
ahead. Go ahead.
Yeah, full screen. Just make it full screen. That's it.
I'm very sorry for the.
No,
Yeah,
go
it's
ahead.
okay.
Just go
No,
ahead.
it's okay. It's
Go
okay.
ahead.
No worries.
Go ahead.
It's okay. Relax. No issues.
I think 2 devices are there. Please take care of that. 2 devices will
Yeah,
produce a lot of disturbance.
Echo will happen. Yeah. One you switch off then. Log out of one. Yeah. Again,
Yes,
it's
Anima,
gone.
Doing
please.
the wrong one.
Aditya, help her because she is looking stressed.
Yes, sir.
Yeah.
No, just relax, but everything is fine.
Anima, relax.
Relax, Anima. This is not examination. Simple presentation.
Balram
It's just
sir,
a discussion
None of us are
among
actually
all of
examiners
us.
of
Yeah.
now.
Yes, so I think my screen is now visible.
Yeah, we need a slideshow.
Yeah, it's okay. It's okay. Fine now.
Great.
Go ahead. Go ahead.
Perfect.
For today's discussion is falsely undetectable TSH in a cohort of South Asian euthyroid patients. As we know that third generation automated immunochemiluminescence assays with functional sensitivity of less than 0.01 micro-international units per ml have now become the standard of care for TSH lab assessment. TSH assay is a sandwich assay comprising capture antibodies and detection antibodies, which are usually monoclonal to achieve a high selectivity. One antibody targets the beta subunit and the other is usually targeted to the alpha beta interface or the seed belt region to detect intact and functioning TSH hormone. So clinically, euthyroid lady in the North California population was found to have an undetectable TSH over a period of 9 months, multiple samples on the Advia Centaur TSH3 Ultra assay. She was initiated on methimazole. As a result, the TSH remained undetectable, and it was repeated on another platform where it was found to be more than 75 micro-international units per ml. Methimazole was subsequently stopped and the TSH was repeated again. It was still suppressed on the Siemens platform and normal on another platform. So this study was then initiated to identify all the discordant test result patients with suppressed TSH in the Kaiser Permanente North California population to collect their medical records and to advise discontinuation of any inappropriate medication if they were receiving it, and also to investigate why this TSH was undetectable in these patients. So the Siemens Advia Centaur TSH3 Ultra platform has been implemented from March 10, 2010 in this population, and 1.6 million individuals underwent this test. Out of these, 4,898 individuals with 2 or more subsequent values of TSH of less than or equal to 0.02 were screened. These patients were excluded if their TSH on subsequent testing was more than 0.05, if they had biochemical features of primary hyperthyroidism, including an elevated total T3 or free T4, if they had received methimazole therapy prior to March 2010, indicating a diagnosis of primary hyperthyroidism, if they had central hypothyroidism, or if they were receiving TSH suppressive therapy for thyroid carcinoma. The 478 patients retrospectively identified in this way then underwent prospective identification. In this, 4 patients were diagnosed by identification of physicians who found the patients to be clinically euthyroid with a persistently suppressed TSH. After July of 2012, the company, in any patient with a TSH on this third generation platform of less than 0.01, or a TSH between 0.01 to 0.02 with a low normal free T4, repeated the test on the ABOT platform. If the results were concordant and the TSH was suppressed on both these platforms, then these patients were excluded. While if the results were discordant and the patients had a normal TSH on the ABOT platform, then these patients were included. 2 patients were subsequently identified through a chart review in which they were found to have a normal radioiodine uptake and normal T3 and T4 levels. And the remaining patients underwent a repeat test, out of which 3 patients were identified. So in all, 20 patients were identified from among this 1.6 million population. All the discordant patients underwent repeat testing on up to 8 platforms. Since the TSH3 Ultra assay uses a fluorescein isothianase and isothiocyanate and anti-fluorescein isothiocyanate antibody on the magnetic solid phase interaction, the company devised a experimental assay in which this FITC anti-FITC interaction was replaced by biotin streptavidin interaction to rule out any anti-FITC interference. TSH still remains suppressed. And to rule out heterophile antibody blocking, they used a blocking agent and the TSH still remains suppressed. So 4 of the Siemens platforms failed to identify the TSH in these patients, while the second generation Siemens assay identified the TSH as normal. As a result of this, experimental assays were devised in order to assess whether it was the capture antibody or the detection antibody on this third generation assay that was failing to identify the TSH. These hybrid assays contained antibodies from both the third generation assay and the second generation assay. PCR for TSH beta was also performed in 12 patients. So as we know, these 4 Siemens platforms failed to identify the TSH, while these 4 other platforms identified the TSH in patients who were clinically euthyroid. In the experimental assays, 2 patients who underwent repeat testing on the TSH second generation and third generation ultra, as expected, the TSH was normal on the second generation assay and low on the ultra assay. On the hybrid assays, the assay which had the capture antibody of the third generation assay and the detection antibody of the second generation assay failed to identify the TSH. The TSH was falsely low in these patients. So it was concluded that it was this capture antibody that may have been responsible for the falsely low TSH results. Subsequently, they identified that the capture antibody was responsible, they sought to determine whether the individual monoclonal antibodies on all the 4 affected assays may have been binding to the same epitope of TSH, which may have been responsible for the undetected TSH in all these patients. For this, they used 2 assays. One was the commercial third generation TSH assay and the hybrid assay, which had the solid phase antibody and the TSH2 detection antibody. They found the relative light units using a controlled TSH at baseline. Then after that, they added an excess of free but unlabeled antibodies, monoclonal antibodies, from each of the assays that was failing to detect the TSH. Now, if the addition of the unlabeled antibody was going to inhibit both the assays, it would be interpreted that the binding site of these antibodies and the solid phase antibody, which was common to both the assays used in this experiment, was common, and then they shared the same epitope. If the unlabeled antibody was going to inhibit just one assay, then it would be assumed that it is the detection antibody that was used in the inhibited assay that was competing for the epitope with these unlabeled antibodies. And if no inhibition was observed, then it would be concluded that these unlabeled antibodies were binding to a different epitope, and the assay antibody epitopes were now free and would bind to the TSH and the signal would not be disrupted. So when they did this experiment, they found that the dimension detection antibody and the Imulite solid phase antibody, when they were added, the relative light units significantly decreased. There was over 40 to 80% inhibition of the signal, which meant that these antibodies were competing for the same epitope as the TSH3 solid phase antibody. They also, on retrospective analysis, found that all these patients identified as South Asian and all the patients who had undergone mutation testing had the same arginine to glycine substitution at the 55th amino acid of the TSH beta chain. So based on the falsely undetectable TSH results, 7 of these 20 patients had been incorrectly diagnosed with hyperthyroidism and treated, while 2 of the 20 individuals who were primary hypothyroid had an erroneous tapering of their levothyroxine dose as a result of the falsely low TSH. They concluded that this arginine to glycine substitution may be altering the epitope on TSH, which is required for the antibody, the capture antibody binding, and this may be responsible for the abnormal undetection on the 4 affected assays. This is another paper published in Thyroid in 2015, in which they found a family of patients who harbored this R55G variant, and they found that each of the alleles was responsible for the phenotype. So in this consanguineous family, patients who were heterozygous had a TSH which was half of the normal on the other platforms, on the Siemens Imulite and the Centaur platform. And in the homozygous individuals, the TSH was undetectable, meaning that even the presence of one allele may lead to a falsely low TSH. So to conclude, physicians and laboraticians should be aware that certain TSH variants may make the TSH undetectable in the hyperselective assays. And in case of suspicion, testing using another platform may be recommended. The estimated prevalence of this discordant patients in their population was 0.001%, but it may be higher in South Asians, as all those patients had identified as South Asian. And now this regional laboratory, what they do is that all their patients with TSH of less than 0.03, they repeat the TSH in an automated format on the second generation assay in order to prevent any erroneous reports. One limitation of the study was the assay developers of the Siemens did not have epitope sequence information for the antibodies. So it could not be definitely concluded whether this arginine to glycine substitution lies in the region of the epitope of this capture antibody or not. Thank you.
Dr. Anima, it's a very fabulous presentation. There is no doubt about that. I think the clinical methods are still valid. Okay, valid points for achieving a reasonable diagnosis. All these things are probably very rare, but always we should consider discordant cases. That would be the carrier message. And there's a beautiful question here that's related to Dr. Anima's paper. Suppose in hyperthyroid patient, TSH remains suppressed despite normalization of T3 and T4. So this is from Ludhiana, Dr. Surender. I think this is a very common phenomenon to get suppressed TSH in the initial phases of treatment. Very, very common problem. Okay. No other case in the chat box. Say, Sarda ma'am, you can have your own comments in this moment. Please take over.
Yeah, I think we have the questions from the previous one, which we're not answering right now.
Which one?
Yeah, there are a few questions also,
Yeah.
sir.
Yeah.
Mr. PR, I am a surgeon. We do USG to diagnose MNG. What do you suggest to us? Trap to diagnose the MNG? So, would you like to answer it?
Yes, Balram sir, please go ahead.
Aditya, are you there?
Yeah.
Aditya.
If the patient is having hyperthyroidism, we would like to do our TSH receptor antibody levels and then go ahead, and if the TSH receptor antibody levels are negative, then we can go ahead and do a technetium maintenance scan to see for the nodularity. But if we have both the investigation in the hospital, then may as well go ahead and do both the investigations, sir.
The question is, he's a surgeon.
Yeah, I think he is there. We have to tell clearly that what we are talking about is in terms of toxic MNG versus a Graves confusion. And what he is talking about is a euthyroid multinodular goiter. So euthyroid multinodular goiter, the modality of investigation is entirely different. We have to go with ultrasound, do the TIRAD staging and all those things. When we are talking, what we were discussing in the paper is like toxic MNG versus Graves, where we have a doubtful uptake and we are not sure. There, the question of the TSH receptor antibody comes. So I think that's the message we are trying to convey.
And the major limitation of the paper was also that they didn't get the USG done. Means the nodularity was not actually, they didn't even try to evaluate that.
Yes.
And they didn't do any FNAC also to rule out any malignancy or other options. Means they were simply focusing only on the either the antibodies or either the scans, but the nodularity was actually not excluded in that particular paper. So that was the major limitation of that particular study.
Absolutely.
So I think
there's one more question.
Doctor, you have got your answer by Dr. Pramila. There is one more question.
Why the prevalence of PTC has increased? Is it iodinization of salt or testing and awareness?
So I think actually the awareness is more important now, and because of the better availability of the modalities, as well more awareness in the patients, because initially we used to see used goiters, but now that scene is uncommon in our OPDs. Whenever they have some nodularity, the patient is now coming to the endocrinologist or to the surgeons or to the ENT surgeon, and ultimately they are being diagnosed. So I think the awareness is having the major contribution in the increased prevalence of ETC in the present scenario. Dr. Pramila, Dr. Jawad, would you like to add something?
No, nothing, sir. Nothing from my side. Pramila ji, please.
Yeah, I think it is the awareness is more, and also the diagnostic modalities. Now we have ultrasound scans which can pick up even very small nodules and we can clearly see, and all those things are also available. So I think more of diagnostic modalities, more diagnosis is being done and we are picking up more. And there may be varied reasons for increase in malignancies for all reasons. Not iodine is not the cause, but there may be many other causes also. So
I think the endocrine disruptors should be kept in mind.
Yeah, that endocrine disruptors and all can be.
Definitely.
Yeah, so
that is one thing which we
when we talk of malignancy. See what Balram, as far as the nodule awareness is concerned, that's fine. They'll come sooner to you with the size of the nodule. But the question is, why is malignancy going up?
Ma'am, if I can add something. So most of the papillary carcinomas, so there has been a huge increase in the number of
that is the question
diagnosed, but most of these are micropapillary carcinomas. So if you look into the actual mortality and morbidity from thyroid, differentiated thyroid carcinoma, that has not actually changed. That has remained static. So there are actually doubts whether if we are detecting these micropapillary carcinomas, whether they should be detected or not, how it's going to change the clinical practice scenario. That's a gray area altogether. So many of these micropapillary carcinomas which are getting detected is because of increased ultrasound, increased imaging, as well as somebody gets a CT scan for some other reason, and we just pick up a nodule and do all the investigations, and the tumor gets removed. So that is why.
There should be a research agenda actually.
Just one more thing to add, because because the person has specifically, doctor has asked about iodine. So there are very few studies, if you see, with iodine and papillary CA, because there are some smaller studies available in literature where they have tried to see the relationship of iodine and thyroid malignancies. Not exactly only papillary, but yes, thyroid malignancies. And they have shown in some smaller studies that if patient has excess of iodine, then it may affect the thyroglobulin antibody level. And actually the thyroglobulin antibody high is one of the risk factors for increased incidence of papillary thyroid CA. So those are like small studies, not like something which is very much confirmed at the moment, but there are some small data available with that. So there are studies coming up because people are debating this question that excess iodine may lead to increased thyroglobulin antibody. Maybe that is increasing the prevalence of papillary thyroid CA, but these are all smaller studies. We cannot make a final comment on that.
This is a research agenda. That's what I said. Yes. So we need to look into so many different aspects of it, but the prevalence is increasing. That's for sure.
So that's one of the factors.
Really, the shift is also happening because if you remember the data from Trivandrum, so there is something like overdiagnosed carcinoma is also papers are coming up. So you can't say say it's increasing, but definitely it's increasing because of whatever set causes. There's no doubt, but there is an element of overdiagnosis also. There are papers for that.
That is true.
Can we move on now, please?
Yeah, please.
Thank you. Thank you. Yeah.
I think the time is there for quiz now.
Yes, Ashmita. Yeah, perfect.
Yeah.
So we have Saptarshi with us. Thank you, Saptarshi, for joining us. It's a pleasure to have you with us. And Saptarshi, Senior Consultant Endocrinology at Indraprastha Apollo Hospitals in Delhi. And he's been past Director, EA Health Diabetes and Endocrinology Center at Noida. And he's Executive Committee member of the Endocrine Society of India, Founder Secretary of the Delhi Endocrine Society, ex-president of SPEED, which is, I think, one of the most popular endocrine programs that we have. Scientific Secretary Endocrine Week 2020, which is organized by ESI. And if I may say so, I took a lead from there to start the weekly meetings. So Saptarshi, like my guru, more than 60 publications in national and international journals. Over to you. Over to the quiz.
Thank you, ma'am, for the kind introduction. So could we have the questions from the IT team, please? So most of the questions are quite clinical and it has a straightforward answer. So if we could have the questions.
Can you tell them the time also so that they hurry up?
Yeah.
So, sir, we'll start.
Yeah.
So we'll start with the dummy questions. Just activate the dummy questions. Started the, activate the question. Can you see this window?
Go ahead.
Button is to please scroll your screen.
I must say the dummy questions were interesting. So could you just go ahead with the actual questions?
Please, can we go ahead?
Yes.
Yeah.
Yes.
10 seconds for every answer.
Yeah.
Yes.
So there are going to be 12 questions.
So we'll activate the actual.
Yes, Ashmita, please go ahead.
Yes.
So, okay. So the first question, all are true about resistance to thyroid hormone beta except TBG is elevated. I think most patients are clinically thyrotoxic. Goiter is present in 65 to 95%, associated with an increased risk for autoimmune thyroid disease. All of them have all the questions have single choices. So I think, do I need to share the picture is not visible. So how can we show the picture?
Sir, you could directly share your screen.
So I can share my screen, right?
Yeah.
So for next question, this is the picture. For question 2, you need to look into the picture and then just mention the diagnosis.
So those participating in the quiz, you can look at the screen over here. And when you want to answer, you can click the poll icon and go back to the poll and answer your question. Whenever you want to look at the screen, you can again close the poll and come back to the screen.
So if everybody has gone through question 2, so question 3 again, simple question, immune checkpoint inhibitors can cause. So question choice B, you can consider as primary hypothyroidism instead of hypothyroidism. So question 4, all are true about biotin related interference in thyroid assay except. Question 5, again a simple straightforward question. All of the following can be associated with an increased radioiodine uptake in the thyroid gland except.
That's not coming on the screen. Question 3 is, I can only see question 3.
Question
now
4.
Question 4 has come.
So question 5, all of the following are increased with increased radioiodine uptake in the thyroid gland except.
I think if you read out the answers, that will be the 10 seconds almost.
So H mole, struma ovary, thyrotropinoma, thyroid hormone resistance. Question 6. All are ultrasound characters of a medullary thyroid carcinoma except microcalcification, macrocalcification, more wider than tall, hyperechogenicity. Question 7. Serum thyroid binding globulin is elevated with all the drugs except glucocorticoid, tamoxifen, methadone, and 5-fluorouracil. Question 8. So FDA approved Tepeza or triptotumumab for treatment of Graves' ophthalmopathy. So all are true about the drug except it's a monoclonal antibody against IGF-1 receptor, is effective in treatment of milder forms of Graves' ophthalmopathy. Hypoglycemia is an adverse effect, can be an alternative to surgery for proptosis and diplopia. Question 9, again you need to look into this carcinoma thyroid, follicular carcinoma thyroid, medullary carcinoma thyroid, and lymphoma of thyroid. So you just need to look into the histopathology and select the right diagnosis. Again, you need to look into the picture for question 10. So what is the treatment of choice for this particular, for a patient with this particular thyroid? Scan finding, anti-thyroid drugs, surgery. Therapeutic strategy will depend on FNAC and radioiodine therapy. So what is the treatment of choice for this particular case? So we are discussing iodine. So the maximum permissible limit for iodine, daily iodine intake in pregnancy is 150 microgram, 300, 500, and 1000 microgram, which is the right choice. So this is the last question. Again, there is a picture. So if you can look at the picture. So again, you just need to mention the diagnosis. The options are neonatal thyrotoxicosis, congenital hypothyroidism, mean-to-be syndrome, and APS type 1. So I think we have given adequate time. So maybe we can wait for another 10-20 seconds and then close the poll, right?
Yes.
We can allow 30 seconds.
Okay. So just I will show the picture once again. Go back to the slides with pictures. So this was question 12. This was question 10. This was question 9. This was question 2. So this is where you also need to look at the slides other than the poll question. Otherwise, whatever is written in the polls is enough for you to answer in the right way.
So the time is over, sir.
Yeah, and they need to wait for the answers after the talk. Over to you, Dr. Balram.
Thank you. Thank you. Over to
Thank you, Saptarshi.
For very interesting quiz. And the winners of quiz will be declared after the monologue session. And now this is the time for the monologue. And Dr. Virendra Patil is already prepared. And he is going to discuss about the unusual thyroid function test. And he will be presenting in very interesting case studies format. So that will be clinically useful and relevant also. Dr. Patil is Associate Professor of Endocrinology at KEM Hospital, and he has various publications, nearly 40 publications in international journals, and many more publications to his credit. Over to you, Dr. Patil.
Thank you, Balram, sir. And at the outset, I would like to thank Sarita ma'am and all my seniors, as well as Indian Thyroid Society, for giving me the opportunity to share the few case studies of unusual thyroid function tests. So before going to unusual thyroid function test, we should know what is usual. So we all know that TRH comes from hypothalamus. It stimulates the thyroid drops in the pituitary. It will release the TSH, and then thyroid will produce T3 and T4. The most important thing is that the TSH and T3, T4 relationship is inverse in most of the cases. So if the T3 and T4 is going up, TSH should go down, and other way around. And the another most important thing is there is logarithmic change in TSH whenever there is change in T3 and T4. So even milder degree of T4 fall will lead to significant elevation in TSH. And most of the hypothyroidism patients will have low T3 later in their natural history rather than at 0 hours if they are going into primary hypothyroidism of the recent onset. These are the few cases in which hormonal profile and clinical profile they match very, very clearly. For example, T3 and T4 is very low, and that is the reason TSH is significantly elevated.
Can you a bit louder?
Yes, sir. Yes, sir. So in this, these are the usual cases in which T3 and T4 is low and TSH has significantly gone up. There is more than 100. So this is usual case in which hormonal profile and clinical profile are matching. Similarly, with elevated T3 and T4, with TSH suppression, there is primary hypothyroidism. These are usual cases. Going beyond that, we'll be discussing if the discordance between TSH and T3, T4 levels, that is discordance of the inverse relationship, discordance between the hormonal profile and the clinical profile, that is biochemistry and clinical examination findings, and some cases of irregularities between the dose response, hormonal response versus clinical response. To start with, this is a 70-year-old male who had done his routine checkup in which T3 and T4 is less, that is significantly decreased, but TSH is not significantly increased. So this is not following the logarithmic change. So for this degree of T3, T4, TSH should have been very much elevated. So before jumping to the diagnosis of pituitary etiology, that is secondary hypothyroidism, we should know that most of the T4 and T3 is protein bound. So you can say that 99.97% of T3 and 99.97% of T4 are protein bound, and only some portion of it is free. And the most important protein is thyroxine binding globulin. And when this patient, the thyroxine was stopped, that is off thyroxine, this was the thyroid function test. You can see that the free T3 as well as free T4 levels are normal with mildly elevated TSH. So this patient becomes a case of TBG deficiency with subclinical hypothyroidism. So in patients with subclinical hypothyroidism, we don't need to treat all of them. We can just wait and watch in some cases. And if the TSH remains elevated on repeated occasions, we might start the treatment. So to know that this TBG, that is thyroid binding globulin, is a member of serine protease inhibitor superfamily. And this is a X-linked dominant disorders, and it is not very uncommon. You can see that partial TBG deficiency is present in 1 into 4,000 newborns, and the complete TBG deficiency where T3 and T4 will be very less, it is little rare, that is 1 in 15,000. So the learning point is that whenever you're getting such discordant reports, please measure free T4 levels. And if the free T3, free T4 levels are normal and if the TSH is normal, there is no need for any treatment, and you can avoid the potential misinterpretation. Coming to the next case, this 35-year-old lady who presented with lethargy, decreased appetite, and secondary amenorrhea. You can see the thyroid function test with the T3 and T4 are less than their normal range, lower range of the normal range, but the TSH is not elevated. The TSH is also decreased. So this is not following the inverse relationship between T3, T4, and TSH. Before jumping to the cellular etiology, we should get the free T4 levels. In this patient, free T4 level is also low. So that is the reason we are suspecting the central etiology. And the MRI showed that the patient was having empty cella, and she was also having secondary amenorrhea. So this patient was having pan-hypopituitarism because of the Sheehan syndrome. So the 8 AM cortisol was less. Even FSH-LH and estradiol was less. So we are not going to just treat this patient for the central hypothyroidism. We are going to replace with replacement doses of the steroids, as well as we are going to give the sex steroids like estradiol, valerate, and progesterone. So not all the times the central etiology can be so simple. There can be some sinister central etiologies like pituitary adenomas, lymphocytic hypophysitis, or other cellular tumors like craniosynostosis. and the treatment of these vary with the depending on the etiology. For example, in lymphocytic hypophysitis, if you're picking the patient early in the course, pulse intravenous steroid therapy can reverse the lymphocytic hypophysitis, as well as it can preserve the pituitary axis. Patient may not become pan-hypopit permanently. So timely treatment in the special etiologies like lymphocytic hypophysitis is very important. So you need to pick the central hypothyroidism to rule out the sinister pathologies, as well as the most common mistake done by the physicians. So whenever you're treating with the, such kind of patients with the central hypothyroidism, TSH will remain suppressed. So what happens when we treat such patients, the patient might visit physician, then physician will tell the patient that you are over suppressed, you can discontinue the treatment, that kind. So please remember that whenever in all the patients with central hypothyroidism, when the patient is on thyroxine, TSH will remain suppressed. So we are not going to monitor such patients with the TSH levels. We'll try to keep the free T4 levels in the mid-normal range. That is a learning point. That is very important. Coming to the next case, 25-year-old female who presented with apparent neck swelling. So patient perceived that she might be having some neck swelling. Otherwise, she was asymptomatic. That is the reason she went ahead with the thyroid function test as advised by the general practitioner. You can see that the T3 and T4, both the levels are elevated, and TSH is in the upper range of the normality. So this is again not matching the routine pattern of the inverse relationship. So, but you can see that despite having such elevated T3 and T4 levels, the patient was not having any thyrotoxic symptoms. So there was a mismatch between the inverse relationship, as well as there was a mismatch between the biochemistry and the clinical profile. So again, coming to the binding abnormalities, as you know that most of the thyroid hormones are protein bound. That is the reason you need to go for the free levels. So when the free T3 and free T4 levels was asked for, both came normal. So this patient was having thyroid hormone excess, total thyroid hormone excess because of the binding protein excess, but she was not on any oral contraceptive or pregnancy, which is the most common cause of high TBG. So in such cases, you might go for family screening because few patients can be there in the same family with the TBG excess. So to discuss a few points about TBG excess, these are three hormones. So 75% of the thyroid hormones are bound by the thyroxine binding globulin. 15 to 20% is by transthyretin, and 5% is by albumin. So all these hormones can lead to elevation in the total levels because of binding abnormalities. But if you are measuring free levels, they will come normal, and you might avoid misdiagnosis and unnecessary treatment. Some patients might be given carbimazole or antithyroid drugs, just going after the high elevated total T3 and total T4 levels. So you should always ask for the free levels whenever you are expecting such kind of discordance between the biochemistry and clinical features of no thyroidopsis. Another common cause of excess TBG is oral contraceptive pills. Normally oral contraceptive pills contains ethinyl, which is a potent estrogen, and it will lead to elevation of thyroid binding globulins. Similarly, it can also lead to elevation in the cortisol binding globulin. So obese patients who are on OCPs, you might ask for the overnight dexamethasone suppressed cortisol, and it might come unsuppressed. So rather than going for direct diagnosis of Cushing syndrome, you should look for this common problem of excess CBG excess because of the oral contraceptive pill. Rarely, the patients with hepatitis can also have elevated T3, T4 levels with the normal TSH because of the release of TBG from the liver, stored TBG from the liver. And other rare causes can be hereditary mole or estrogen producing tumors, or some drugs like tamoxifen, apart from OC pills, and some liver diseases. Coming to another case, this 40-year-old female, you can see that she's obviously, she has lost weight, she looks cachexic. So she was diagnosed to have thyroid illness since last 5 years, and she was under treatment with some local doctor, and she was put on 25 micrograms of thyroxine, and on this 25 micrograms of thyroxine, she was having anxiety and palpitations. And when the entire profile was asked for, you can see that both free T3 and free T4 levels elevated. At the same time, TSH was also elevated. Based on this elevated TSH, that local doctor might have started on thyroxine, but this patient is not having hypothyroidism. On the contrary, the patient is having elevated free levels of T3 and T4. So again, this is not matching our routine inverse relationship. So whenever T3 and T4 is getting elevated, TSH should have gone down, but in this patient it is not going down. It means there is inappropriate TSH secretion from the pituitary gland, and this is the cause of central thyrotoxicosis. So, and on history, on inquiry, the patient also had headaches since last 1.5 years. And when the imaging was done, patient was harboring a cellular tumor. So this is a TSH secreting pituitary macroadenoma and leading to thyrotoxicosis. And this was inappropriately diagnosed as hypothyroidism by the local physician because of lack of free levels. And when such patients and the management of such patients are not straightforward, these patients might require very high doses of carbimazole drugs because you need to make them fit for the surgery. So this particular patient was given 60 milligrams of carbimazole along with Lugol's iodine. Even after this particular treatment, after 15 days, FT4 remained high. So we had to give injection octreotide, which was available in hospital subcutaneously. And after starting octreotide, after 3 days, FT4 was still it was elevated, but she was fit for the surgery. And patient underwent transperineal surgery, and after the surgery, the levels became better. But not every patient with TSH secreting pituitary adenoma can be in the cella only. Most of the patients can have invasive tumors. So after the surgery, most of the patients might require second line of treatment, mostly external beam radiotherapy. Coming to another case, this 34-year-old female, she again perceived some neck swelling, right sided since 8 years. Otherwise, she was not having any other symptom. You can see that, and for this neck swelling, the patient underwent this TFT. You can see that T3, T4 is elevated. At the same time, TSH is also elevated. So somebody started her on carbimazole, but even on the carbimazole, T3, T4 levels remain elevated. On the contrary, TSH shot up. So again, this is not matching our inverse relationship between T3, T4 and TSH. So to rule out the TSH secreting pituitary tumor, MRI was ordered and it was normal. So this patient was having a normal MRI of the cella with elevated T3, T4 levels and elevated TSH level. So this patient falls in the category of thyroid hormone resistance. So what happens whenever T3, T4 levels are elevated, there has to be feedback. The T3 and T4, they give feedback at the level of hypothalamus and pituitary using TR beta subunit of the thyroid hormone receptor. And if there is a defect in the TR beta gene, which is the most common, the pituitary and the hypothalamus is not able to read the T3, T4 levels well, and it will keep on releasing the TSH. And that is the reason this patient is having elevated TSH in the presence of elevated T3 and T4. And this was one of the questions in the quiz now. The most common symptom is goiter because of high TSH. TSH is a thyrotropic hormone for the thyroid gland. That is the reason there is goiter in most of the patients. And the resistance is not uniform. There is differential resistance. So this T3 and T4 is going to act on other receptors of thyroid hormone at the level of heart, and the patients can have tachycardia, and some patients can have some kind of thyrotoxic symptoms, and you manage these patients with beta blockers. So even these patients are, though they are rare, they are not very uncommon. 1 in 40,000 is the prevalence, and most of them are familial. So you need to go for the familial screening as well. And the differential diagnosis of TSH secreting tumor, you might need MRI pituitary. In the literature, they have given some other tests like TRS test to measure TSH after TRS test, or to measure alpha subunit of TSH after the TRS test. But TRS is not available straightforward. You can ask for the MRI of the cellular region, and if the MRI is normal, because this is a lifelong diagnosis, you need to make the diagnosis very clear. Coming to another patient, this 36-year-old female, she met the dermatologist for patchy hair loss, and that is the reason she was put on some drugs. And she was also asked for the TFTs, which the patient got the TFTs after taking these multivitamins after a few days. And you can see this TFT. The total T3 was more than 800, T4 was normal, 6.48 micrograms per deciliter, and the TSH was suppressed, that is 0.404. And the clinically patient was not having any kind of thyrotoxic symptom. So again, there is a mismatch between the clinical profile as well as the biochemistry. For this degree of high T3, that is 800, patient should have some kind of thyrotoxic symptoms, which was not present in this case. And on inquiry, you can see that this particular multivitamin, which was containing biotin in the dose of 5 milligrams. So this is a huge dose, and this biotin was causing interference in the assay. And you can stop the biotin after for 3 days, and you can get the test. In this patient, patient got the test 1 month after stopping the biotin, and it was absolutely normal. So this was a biotin-related assay interference. So why this happens? Or any assay which is using biotin streptavidin as a molecule in the platform, it is prone for the biotin interference. You can see that this blue particle is streptavidin and the greenish particle is biotin. So the capture antibody is attached to this biotin. So the streptavidin acts like the anchor, and biotin attached detection capture antibody is attached to this biotin. If the person is taking biotin and the biotin is present in large quantities in the serum, in this particular phase, the biotin will replace this biotin-related antibody. So you can see that this capture antibody which should be present here, it is replaced by biotin only. So there is no capture antibody left to detect the antigen. So when in our case it is TSH. So in the sandwich assays, all the assays will be falsely low if it is interfered by the biotin, like TSH, ACT, HPT. All these are capture antibodies, sandwich assays. So in the sandwich assays, the antigen will be low. On the contrary, if you look at the competitive assays like free T3, T4 or total T3, T4, they will be falsely elevated because of the biotin interference. Coming to another interesting case, this 47-year-old person who himself was a doctor, and because of the generalized fatigability, he had undergone, initially he had undergone thyroid test in the February 27, which was normal. Then after a few months, he again got the test, at which time the TSH was suppressed. And you can see that free T3 and free T4 levels were absolutely normal. So at 0 hours, when he contacted endocrinologist, he asked him to wait and watch. And after a few months, again the TFT was repeated, and the levels were similar. The free T3 and free T4 levels normal, and TSH was suppressed. At this point of time, technetium 99 scan was ordered, and you can see that there was uniform increased uptake in both the lobes. The percentage uptake was normal; it was around 3%. So because free T3, free T4 levels normal and uniform uptake, the patient was labeled as a case of subclinical Graves' disease, and he was started on carbimazole 5 mg. You can see that after a few months of carbimazole, the TSH remained suppressed. So that is the reason the dose was increased. And even after taking a higher dose of carbimazole for almost 7-8 months, the TSH remained suppressed. That was very surprising. And when the patient followed up, patient did the TFT from another lab. So it was not asked for, but it was done from another lab. And you can see that the TSH was elevated. So TSH was 17 and free T3, free T4 levels were little down. And at this point of time, the thyroid receptor antibody, TSH receptor antibody was ordered, which was negative. And it was planned to do TFTs from different labs. So in this particular case, there was mismatch between the dose response and the hormone response. If the person is taking 20 mg of carbimazole, in a case who is having subclinical Graves, the TSH should remain unsuppressed, in which case it was not. And that is the reason TRAB was ordered and it was negative. And when the TFT was ordered from different platforms, so the patient sample was sent to different platforms having different laboratories having different platforms. You can see that in 2 labs where Advias or XP was used, the TSH was suppressed, and at other labs it was elevated. So it was just a lab error or beyond it. So this particular topic was discussed by the JC, done by Dr. Anima. And when we went into the literature, we found this paper, falsely undetectable TSH. So what happens, the epitope of TSH molecule, where this capture antibody, where the detection antibody is going to bind, it has changed. So it is just a polymorphism kind of, it is just a change in the single nucleotide without causing change in the TSH functioning. So the TSH is functioning absolutely normally, but there is just slight alteration in the TSH molecule, and because of which this very specific antibody is not able to join. So just for the academic purpose, we did sequencing of the TSH B gene in this particular patient, and in which we found the similar variation. So arginine 75 glycine, you might see that here 55 and here 75. It is because of different transcript use. It is the same variation, and we could confirm this in this particular patient. So, whenever you're getting such kind of, so we have discussed about the cases in which this particular relationship is not following, or there are cases in which hormonal profile is not matching the clinical profile. We'll move ahead with few other cases. Like in this particular patient, 32-year-old female who had incidentally detected deranged TFT. with elevated TSH. When the patient was started on thyroxine, initially it remained elevated. That is the reason the dose was increased by the treating doctor. And even after increasing the dose to 100, the TSH remains elevated. And at this point of time, patient was complaining palpitations and weight loss. So you are creating iatrogenic thyrotoxicosis kind of thing, and patient was getting such thyrotoxic symptoms because of a higher dose of thyroxine used. And because there was discordance in the hormonal response and the clinical response, the TFT was ordered from a different lab. And you can see that in this lab, patient was made iatrogenically high, thyrotoxic, free T4 was elevated and TSH was suppressed. Why was this happening? It was happening because of the head-to-file antibodies. So when the sample was running the dilutions, we could prove that. So like biotin, head-to-file antibodies can also interfere with the assays. But nowadays, many assay platforms, they have a blocking substances to block these head-to-file antibodies. So we don't often see such kind of cases nowadays. But there are some assays, or there are some head-to-file antibodies which may not get blocked by these blocking substances used by the different platforms. So whenever you are having discordance between the dose and the clinical response, you might ask the repeat sample from a different platform, or when you are strongly suspecting the head-to-file antibody, we might go for the serial dilutions, or you might use the blocking sera. Coming to another case, 11-year-old female presented with short stature with gross hypothyroidism, started on 75 micrograms of levothyroxine, and even after taking thyroxine, the TSH remained elevated. So we confirmed the compliance first. We ruled out any other obvious causes of malabsorption, and then a rare cause of malabsorption was looked for. Celiac is rare in our part. That is the reason I'm using rare part. In this particular patient, IgTTG was elevated. So it was a case of celiac disease, and because of the celiac disease, this thyroxine was not getting properly absorbed. And despite taking thyroxine routinely, the hypothyroidism was not getting corrected. But when patient was shifted on the gluten-free diet, the inflammation in the small intestine disappeared, and the patient responded to a smaller dose of thyroxine, and patient is doing quite well on this. Another case where the dose response was not matching the clinical response. In this particular patient was diagnosed to have hypothyroidism in 2010, and patient was started on thyroxine. Despite gradual increment in the thyroxine dose, the TSH remained elevated. So again, you're getting discordance between the dose as well as the biochemistry. The common causes of compliance was ruled out. There was no malabsorption. Even celiac disease was ruled out in this particular patient. Going beyond that, because the patient was requiring such higher doses, during the evaluation, even ultrasound was done, and that ultrasound picked hemangioma in the liver. And so at that point of time, we thought that probably hemangioma is the reason for this kind of higher requirement of thyroxine. And then CT scan and the RBC whole scan body was done, and we proved that it was a hepatic hemangioma. So it was a case of conjunctive hypothyroidism. So what happens in this particular patient? The hemangiomas, they express deiodinase type 3, and deiodinase type 3 will break down T4 into reverse T3. That is the reason whenever the patient is taking thyroxine from the intestine, it will enter the portal circulation, and when it reaches the liver, it is broken down. Most of the thyroxine was broken down into reverse T3, and that is the reason, despite very high doses of thyroxine, her TSH never normalized. So we tried to give her different doses. Even we tried the enucleation, which was partial. So even after the enucleation, patient remained, the hemangioma couldn't be completely removed. So we are managing these patients with higher doses at frequent intervals. We don't know what to do further in this patient. So there are a few case reports in which hemangioma, generally such kind of hemangiomas are reported in pediatric age group. And people, there are some reports that beta blocker, that is propranolol, if the patient propranolol is given, these hemangiomas gradually regress, or they regress naturally as a natural course. But in this particular patient, it was adult onset, and even after the surgery, patient requires higher doses. So coming to another unusual case, this case was managed recently in our department. 25-year-old female presented with some degree of weight loss, but there were no other thyrotoxicosis symptoms. Menses were regular, and the previous TFT was this. T3 and T4 was normal, and TSH was suppressed. So it was case of subclinical thyrotoxicosis kind of picture. On inquiry, so whenever we get some thyroid patients, we might ask for the family history. And because most of the thyroid disorders are autoimmune and they will have family history. Similarly, in this particular patient also had family history. But in the same family, we'll get some patients with Hashimoto's, some patients with Graves. In this particular family, everybody was having hyperthyroid only. So the grandmother, then other two siblings were also having hyperthyroidism, and they were on carbimazole. At that point of time, we thought that it might be some unusual case, and in this particular patient, the TRAB were negative. So these patients were having uniform uptake on the technician scan. TRAB were negative, and there was a familial history, and that is the reason we asked for the genetics, and we could prove that the patient was having heterozygous mutation in TSH receptor. And this is activating mutation. So this is a case of TSH receptor activating mutation presenting with thyrotoxicosis, and the inheritance pattern is autosomal dominant. So in such patients, the treatment choice will be, we might use smaller, because these patients are tolerating smaller doses of carbimazole, we might keep the patients on smaller doses of carbimazole, or we might go for other therapies. Like if the patient is having overt thyrotoxicosis, we might go for ablation or the surgery. So we were, in a nutshell, whenever we are getting such kind of cases where the normal inverse relationship between T3, T4 and TSH is not matching, you should suspect beyond. You might suspect central hypothyroidism or central hyperthyroidism or other etiologies. Always you look for the clinical profile, because clinical profile will always give you some kind of clinical clue. And whenever the patient is requiring higher doses, or there is an inadequate response between the dose and the clinical response, you should suspect that there is something wrong going on, and you should evaluate further. You might take endocrinologist help in such cases. Thank you very much for the patient listening.
Patel, for the excellent presentation, and every case was eye-opener, but I think the consumptive case was the case which was having the hemangioma. That was the most interesting case to me. Would you like to explain your experience about the utility of octreotide, as you just mentioned in one case?
Yes.
That you use the octreotide in those cases where they were not responding to the antithyroid medications. So what is your experience about this particular entity? Because many a time you are in a fix that you are not able to use the antithyroid medications because of various issues or the granulocytosis. So do you have any experience about?
Yes, yes, sir. So we have 7 to 8 cases of TSH secreting macroadenomas, pituitary macroadenomas, leading to central thyrotoxicosis. And in 3 of them, we had to use octreotide. So in this particular lady, despite using very high doses of carbimazole, she was not getting euthyroid, or she was not getting in the good enough levels to be fit for the surgery. And that is the reason we had added Lugol's iodine. And even after adding Lugol's iodine, there was no significant decrease in the levels. And that is the reason we had searched for the literature, and we could find that octreotide reduces the TSH secretion, and it might act at the level of the pituitary tumor. And that is the reason we had to use subcutaneous octreotide for a few days only before she was fit for the surgery. There is another case in which the patient is having co-secretion of TSH as well as gonadotropins.
Okay.
So in that particular patient, the patient was secreting FSH, LH as well as TSH, and the testosterone level was so high that patient was having abnormal social behavior, behavior of gambling, and despite the surgery, the tumor could not be removed completely, and that is the reason patient was subjected to external beam radiotherapy. But even after the EBRT might take some time for the tumor response. In that meanwhile, that period, we had to use long-acting octreotide in that particular patient. And with the use of long-acting octreotide in that particular patient, both the testosterone level as well as the TFTs were much better when the patient was put on monthly octreotide therapy. So we have used octreotide only in 2-3 patients with TSH secreting pituitary tumors. Other patients, I could remember that recently we managed young engineer, 27-year-old. He had done a routine blood panel, and in that TFT was abnormal. That is the reason he had visited the hospital. When we asked for free levels, both free and free T3, free T4 was elevated. TSH was normal, 2.5, and MRI was showing a big tumor with the paracellular extension. So after the surgery, almost 70% of the tumor was out, and patient became a little better. But immediately after 2 or 3 months, we had subjected the patient to EBRT, And we had to give carbimazole only for few months. After the EBRD, the patient is absolutely doing good. We did not require to use opioid in that particular patient.
Thank you, Dr. Virit, for the excellent explanation and presentation.
Yeah, Balram, we need to move on to the quiz answers, please.
Yes, ma'am. So this is the time again to invite Saptrishi for the answers and then finally the declaration of the winners.
Yes.
So thank you. I think it was an excellent presentation, and most of the answers actually I think have been given by Dr. Virendra in his presentation. So it was really an eye opener for so many of us. So let me share my screen. Just a minute. Okay, we have the answers now. So the first question was, I think it's already, part of it has been explained. So the choices all are true about resistance to thyroid hormone beta, except, so most of these patients are actually clinically euthyroid. So the answer is B. So all are true about thyroid hormone resistance. Is most patients are clinically thyrotoxic is the wrong answer. So most of these patients are actually clinically euthyroid. And actually the TBG concentration is elevated because of the chronic stimulation by TSH. Goiter is present in 65 to 95%. There are some features of thyrotoxicosis, but they occur in only 1/3. Even there might be some features of hypothyroidism, but most of them are euthyroid. And there is an increased association with thyroid autoimmunity. So this was the second question. So you can see there are puff of smoke-like appearance in the cerebral angiogram. So this is Moyamoya disease syndrome or Moyamoya disease, and it has an association with Graves' disease also. So it's partly autoimmune, usually seen in Asian women, in young middle-aged women or younger women, and occurs due to coronary or cerebral vasospasm. And then there is a capillary vascular tuft formation, which gives this characteristic pattern on angiogram. So the answer, and it has a association with Graves' disease. So that is why this question was asked. So the answer is Moyamoya disease or Moyamoya syndrome. So immune checkpoint inhibitors can cause central, primary, painless thyroiditis. They can cause actually all of them. So the answer is all of the above. So they can cause hypophysitis, they can cause transient thyrotoxicosis followed by recovery, or it can be followed by primary hypothyroidism. So they are known to cause all types of thyroid dysfunction. The answer to question 3 is all of the above. I think it was discussed, Dr. Virendra already discussed it. So all are true about biotin related interference in thyroid assays, that the TSH is usually suppressed. T4, T3, and even the anti-TSH receptor antibody can be falsely high. And it was already explained the difference between the sandwich immunoassays and the competitive immunoassays. So the TSH utilizes a sandwich immunoassay, and that is why we get a falsely low reading. So the question 5 was all of the following can be associated with an increased radio uptake in the thyroid gland. So that is important. So in case of struma ovary, so there will be an increased radioiodine uptake in the region of the ovary or in the region of the tumor. So it's not a thyroid gland which will show the increased uptake. In rest of the cases, H-mole, thyrotropinoma, or thyroid hormone resistance, there is TSH stimulation and the thyroid gland uptake for radioiodine will be increased. So the answer to this is struma ovary, or B. Again, the question 6, all are ultrasound characters of medullary thyroid carcinoma except microcalcification, macrocalcification, more wide than tall. And the choice is, the answer is hyperechogenicity. They do have hypoechogenicity as a feature, and hyperechogenicity is practically not seen. So out in this meta-analysis of 157 MTCs, there is not a single case, but they can have micro, macro. Unlike the papillary and follicular CA thyroid, they are slightly slow growing. So that is the reason they are more wide than tall. So tumors which are rapidly growing, say they tend to grow along the plane of the neck, and they tend to be taller. Tumors which are slightly slowly growing, they tend to be wider. Again, this related question was already discussed. So the question 7 was serum thyroid binding globulin is elevated with all the drugs except. So answer is glucocorticoid. So these are the list. So androgens, anabolic steroids, and glucocorticoids, they can falsely decrease TBG. Rest of them, usually the other ones, usually increase TBG. So for this question 8, Tepeza, which is approved for Graves' ophthalmopathy. So the answer is hypoglycemia is an adverse effect. That is the wrong answer. So that does not take place. So the answer is hypoglycemia is an adverse effect. So it usually causes hyperglycemia, and this is one of the drugs which can be used in mild to moderate Graves' disease as well, and it has Graves' ophthalmopathy as well, and it has evolved as a substitute for surgery in many cases. So this is a new molecule, costly, not yet available in India, but the usual side effect is hyperglycemia rather than hypoglycemia. So this is a medullary carcinoma of thyroid. You can see there are you can see the fibrous capsule, and the tumor cells are arranged in solidness and focal follicular pattern, and you can also see eosinophilic deposits of amyloid. So amyloid, if it's present, it's usually almost diagnostic of medullary thyroid carcinoma. So even though there are some other rare causes also, like primary amyloidosis, but in most of the cases, if you see amyloid, it's strongly suggestive of MTC. So this is a toxic autonomous nodule. So the definitive treatment will be radioiodine therapy. So here, so that is the treatment of choice in this case. The answer is going to be D, radioiodine therapy. So the maximum permissible daily iodine intake in pregnancy, so 150 microgram is the recommended dose. And according to the ATA 2017 guidelines and other studies, it's maximum a lady can have is up to 500 microgram. So after that, it can have effect on the fetus. So this is the final question. So what is the diagnosis? So this is actually a craniosynostosis. So it can occur in neonatal thyrotoxicosis. So if this can happen, this is rare, but the answer is neonatal thyrotoxicosis. So thank you once again for your participation, and if we can now look at the winners from the IT team.
So are we Mansi?
So congratulations to the winners. So the winners are Dr. Manasini Bhatt, Dr. Sindhuja Reddy, and Dr. Parul Gupta. So they will be given certificates. Congratulations to all of them. So I think there was a lot of participation. So it's great to connect with more so many young doctors who are present for this webinar.
If I'm not wrong, Dr. Parul is a very regular. Last time, I think she came first. So at least she's maintaining the top 3 positions. So thank you, Saptarshi.
Thank you. Thank you.
Thanks to you. The quiz is always an attraction, and that was a great discussion that we had as far as the answers was concerned. Thank you so much.
Thank you.
Over to you, Dr. Balram.
So thank you, ma'am. Actually, I also enjoyed the whole program, and this series also I'm enjoying regularly. So thank you again for inviting me, Dr. Sarita ma'am, Dr. Pramila, and the whole team. And I really enjoyed the program, and I wish to be there again and again in such kind of programs. Thank you. Over to you, ma'am.
Thank you. Pramila, are you there?
Yeah. Yes, ma'am, I'm there. Thanks, everyone. It was really nice. We had a nice discussion. Thanks, Dr. Balram, for chairing the full session, Dr. Jabbar for being a part of it. And we had nice two journal clubs by 2 senior residents. And then we obviously had the best attraction of today. That was the quiz. That's always the attraction for the students, actually, I should say. But yes, we learn a lot from the journal clubs and from the case discussions and all the inputs given by different faculty who are a part of this. And also Dr. Viren took us through interesting cases of thyroid, how we can interpret the thyroid functions and what all patients can present with. So I think it was really nice today. And again, I would request the audience also, if you have any case reports, any articles, please send it to Thyroid Research and Practice Journal. We need articles, and it's our Indian Thyroid Society journal. So please send your articles to the journal so that we have our enough articles and case reports to publish in our journal. And I think we also know that we are, you can all see that we are celebrating World Thyroid Day on 25th of May. So please join us. We have an interesting program coming up, which will be from 7 to 9:30 p.m. with both national and international faculty. So I would just request Dr. Sarita ma'am to just give a brief, and then we will close for today.
Yeah. Thank you. Thank you, Pramila. Thank you to Dr. Jabbar, Dr. Sharma, Dr. Viren Patil, and both the SRs, Anima and Aditya. Thank you for joining us. I think this has been a great session. We've gone through 2 journal clubs. I agreed, though of course the article was a little older, the 2014 article, but it was very relevant in the context of the cases that Viren presented. Because they said they have seen such cases, you know, with those TSH mutations. So then I said, okay, let's go ahead with that journal club. So usually one prefers to take journals which are published in the same year or maximum a year earlier. So both of them have been learning experiences, and we've had a good discussion on when to do thyroid receptor antibodies, about TSH variants. And of course, all the cases that Viren presented have been a great learning experience. Thank you. Thank you very much for all of you for being with us. I think what Pramila wants me to highlight is the fact that the next Wednesday, and this was the whole purpose of organizing meeting on Wednesdays, apart from the fact that it has worked out well, being the middle of the week, and since a lot of people are now traveling, so I think that has suited us. The reason was because World Thyroid Day is next week itself, which is the 25th of May, and we are having a lot of presidents on board with us. We have Dr. Rakesh Sahai, who is president of the Endocrine Society of India, Dr. Deena Shrestha. She is the president of the South Asian Federation of Endocrine Societies. And we have Professor Simon Pierce with us, who is the president of the British Diabetes Association. So you can see there's going to be another very, very exciting session with 2 talks and 2 panel discussions. So do please join us next week. This will be a little longer. It will be from 7 to 9:30. But I'm sure you will enjoy that as well. I'm sorry you will miss out on the quiz, but I hope that doesn't discourage you for not coming with us. Thank you. Thank you very much. Thank you to the digital team. Mansi has been with us throughout. Thank you to Medisage as well for their participation. Thank you, everyone. A very, very good night to you. Thank you.
Thank you. Good night.
Thank you.
Good night.
Good night. Thank you.
Good night, Minnie. Thank you for being with us. I'm sure Arun is there also. And we have a rapporteur who will be joining us from next Wednesday, Dr. Gandhi. She's also there. Thank you, Gandhi. Thank you very much. Good night.